Welcome, everyone. This is Dr. Leila Hariri, a 20-year dentist right here in Dubai as your cosmetic and general dentist, and now also an airway-focused dentist. And I am super pleased to have my team here, Dr. Sasha, our ENT, Dr. Simran, our pediatric dentist, Dr. Gayatri, our orthodontist, to help us unravel something that actually goes really unmissed with most parents, including myself, as something cute, and that is snoring in our children, or if they have mouth breathing, whether it's during their sleep time or even their wake states. This is not something cute, guys. This is called pediatric obstructive sleep apnea. And today we're going to unravel everything about it. And the effects that it has on our children can be anything from their breathing, their sleep quality, their growth, behavior, school performance, that's a big one, heart health, metabolism, and even facial development. So today we're going to break it down in a very practical way. We'll uncover what exactly is pediatric OSA, why it happens, what signs parents should look for, what dental and ENT exams can reveal, what tests are used, what treatment options exist, how successful those treatments can be, and what happens when treatment works. Let's begin with the most basic question. What exactly is pediatric OSA, Dr. Simran?
So, Dr. Leila, pediatric obstructive sleep apnea is essentially when a child's airway is partially obstructed or narrowed, and it affects the way that they breathe. And this condition, it essentially restricts the airflow. And the airway can partially collapse or narrow, as I mentioned. And it's part of sleep disordered breathing. So it's important to remember that sleep disordered breathing is actually a spectrum. So on our more milder end of the spectrum, children are harmlessly snoring. And then towards our other end of our spectrum, more severe, we have obstructive sleep apnea. In the middle, we have children who have, say, upper resistance airway syndrome or obstructive hyperventilation. They also are on the spectrum. So sleep disordered breathing is a spectrum, and obstructive sleep apnea is on the more severe end.
Another thing is that parents might assume that kids are just snoring. Now, snoring is relatively persistent, but these like drops or the episodes where the airway collapses and children find it difficult to breathe, they may be more sporadic and more distributed over the night. So if a parent is walking into a child's room and just observing snoring but misses the time when the episode actually happened, they may assume that it's just snoring and completely overlook the fact that it might not just be snoring. So if snoring is a symptom, it's definitely important for the parent to bring the child so that other aspects can be evaluated, can be looked into.
So I would assume as a parent that I would ask, is snoring normal in my child, Dr. Simran?
That's a very common question that we get. And occasional snoring when a child is maybe unwell or they have a cold, that can happen. And usually once the child recovers, they stop snoring and it settles. However, habitual or regular snoring, that's not normal. It's reported that children actually snore habitually or for a long time in about 3 to 12% of children, whereas obstructive sleep apnea is recorded in about 1 to 3% of children. And in some studies, it can be up to 5%. So it's a relatively low percentage, but it shows that not all children who snore have OSA.
But I have to correct this data. So you just mentioned that habitual snoring might occur in 3 to 12% of kids, but according to some studies, parents might observe occasional snoring in even up to 15% of total number of kids. And if we include objective diagnostic methods like polysomnography, this number can be even higher, up to 25 to 30%. So families and parents sometimes really don't catch always what is exactly happening at night.
And I think sometimes it's also underestimated. If it's recorded maybe about 15% of children, but then the PSG may show actually a higher score. So typically parents can underestimate, their child's snoring or how regularly frequent they're snoring.
Very true. So, what exactly is the cause of pediatric OSA, Dr. Sasha?
Basically, the core idea is that pediatric obstructive sleep apnea develops from interaction between structure and function, and many times it's not really always caused by one thing alone. And the airway can become vulnerable, sensitive, and collapse because of a mix of anatomical narrowing, then airway collapsibility, just lack of particular tone of muscles, neuromuscular control, ventilatory control, and arousal responses. And during wakefulness, many kids may compensate partial airway collapse because at that time their neuromuscular tone is higher, but during the sleep, especially during deep sleep, when the muscle tone falls, the same airway which during the day is quite resistant may become unstable. And again, the major predisposing factors that we are going to discuss a little bit more during this podcast are, from my perspective, anatomical issues like hypertrophy of adenoids and tonsils. Of course, obesity is one of important factors where you have compression on the soft tissues from the outside tissues, then craniofacial abnormalities. You two will hopefully tell a little bit more about this, and of course some neurological and neuromuscular abnormalities.
Yes. I mean, from a craniofacial standpoint, there is a very strong correlation between the development of the upper and lower jaws and the position of the tongue, the lower jaw, with the airway itself. So, if the child's upper jaw or the lower jaw do not develop to the expected point, then it's either a retrusive upper jaw or a retinognathic lower jaw, which is causing the child to keep the mouth open, breathe from the mouth, and that essentially causes like a downward and backward rotation on the lower jaw. And that, because the tongue is in a low posture, it doesn't assume the position that it's meant to assume, and that's very strongly correlated with an airway issue. So if at all we have a child that walks into the office but they're not completely aware, or the parent hasn't observed any of the airway specific symptoms, but they bring them in for an orthodontic examination where they've observed, like crowded teeth, or they've observed very narrow jaws, or they've observed that one of the jaws is not growing properly, or it looks like the lower jaw is very much behind in comparison to the upper, then these elements have a very strong correlation with a narrow or a constricted airway in general. So I think of the list, the top three would be an underdeveloped upper jaw, an underdeveloped lower jaw, and increased lower facial height. Children with very long lower thirds of the face. So these just some tips for the parents. If children depict facial features which replicate a long face, then that might be an indication to at least come in for an examination.
Very good point. And if you had to name the most common cause in children, Dr. Sasha, what would it be?
I would probably say, and it's not just my opinion, but according to multiple studies, the hypertrophy of either adenoids or tonsils or both. So these are lymphatic tissues. They are present in all kids. At the age between 3 and 7, they are relatively the biggest in comparison to other dimensions of the face of the airway. So most of the kids who might suffer from obstructive sleep apnea or just problems with the breathing during the sleep are in this age group. So they are normally present in all kids. Unfortunately, some kids just genetically, just by default, may have them much bigger, and then the airway may get blocked to maybe 70, 80, 90% of what would be ideal, and especially with adenoids. We have this simple grading system where we have 4 grades of adenoids based on the percentage of the level behind the nose, where grade 1 is blockage up to 25%, grade 4 is blockage between 75 and almost 100%, where I see kids who have 90% of the airway block. So generally, hypertrophy of adenoids tonsils are going to increase airway resistance, reduce nasal and postnasal space, reduce pharyngeal space, and generally promote mouth breathing, which also can affect dental development.
Exactly,
Uh,
and chronic mouth breathing in dentistry is definitely something that we look at as airway-focused dentists. And as Dr. Gayatri mentioned, if somebody or a child is chronically mouth breathing, they always have their mouth open, especially during the developmental years. It promotes a downward a downward growth pattern. So we can see a long face, an increased lower third facial height, also bite problems developing as well. So that's all linked to chronic mouth breathing.
Amazing. And can you actually explain the mechanism, Dr. Sasha, that this works?
But this is fairly simple. I mean, during inspiration phases, we create negative pressure to primarily pull the air out from the lungs. But as the airway becomes more narrow, this negative pressure, especially in kids who may have poor neuromuscular control and more collapsible airway, is going to pull already narrow airway inwards, which is ultimately leading to the collapse and complete closure of the airway and basically cessation of the normal flow of the air through the airway, which is going to reflect on cardiopulmonary functions, level of oxygen in the blood, level of CO2 in the blood. And this is how it happens.
So basically, it's a collapsible tube that is very sensitive to the pressures from the surrounding tissues. So whenever that threshold of the negative pressure is crossed, the airway just buckles and collapses. So that's why most of the nights, even though things appear to be normal or the child in the day appears to be normal, it is very rapidly progressing once that threshold is crossed. So there can be a good few episodes of buckling that happen, and this is why, again, it needs to be looked into because it's so sensitive to the surrounding structures that, yes.
And is the blockage, would you say, in one area specifically or multiple areas?
But at least the area that I am observing is not the rigid, it's, as we agreed, collapsible area. So most of the times it's several areas that we need to monitor and observe. Could be the level of the nose, allergies, hypertrophy of the nasal turbinates. Okay, again, with the kids, most common are hypertrophy of adenoids and tonsils. Adenoids is lymph tissue which is sitting at the back of the nose in this transitional area between the nose and the throat that we call nasopharynx, then the pure throat, but also the tongue base, epiglottis, also all the way down to the beginning of the lower airway, which is a rigid tube. So, starting from the bronchial tree, you have the cartilage skeleton, which is keeping this area more or less rigid, but up to this level, everything is collapsible.
Interesting. Okay, so let's try to keep this simple for parents. What should parents look out for at night, Dr. Simran?
So there are several nighttime signs that a parent can look out for. So that may include loud or persistent snoring, gasping or snorting whilst they're sleeping, restless sleep, perhaps tossing and turning, sleeping in unusual positions, nighttime sweating, and even bedwetting. So obviously at a young age, maybe some bedwetting is expected, but as a child grows older, you expect a child to stop bedwetting. So that's, a sign to look out for as well. Also chest retractions, paradoxical chest movements. So these are all signs throughout the night that a parent can look for.
Thank you for that. And Dr.
So, just to expand on the paradoxical chest movement, usually when you inhale, the chest tends to expand. But because these kids have to make a bigger effort to suck the air in because the airway is collapsing and that threshold is crossing, the chest muscles could move further inwards actually because of effortful respiration. So that could be a subtle sign, easily missed by parents, but it could be something that they might catch on to when the child is asleep.
And what about mouth breathing?
Yes, definitely. So mouth breathing during the day and during the night. That's definitely a sign for parents to look out for.
And many parents assume that if a child isn't sleeping well, they'll simply look very sleepy during the day. Um, is that usually the case in children, would you say?
Not necessarily or not always. Yes, children can present quite sleepy during the day, but typically younger children will present quite differently, say, than to an adult, compared to an adult. So children may appear actually more active or more unsettled, maybe more hyperactive. Parents may notice they're a bit more irritable, or emotional outbursts, or difficulty regulating their behaviour. And typically school teachers, so in a school setting, teachers may notice, poor concentration, perhaps memory issues, and it can actually affect their academic performance in school.
Hmm. And then that I know leads to a host of things, with the life we live, with medications and do this and do that, which I think it's quite unnecessary. But anyhow, I'll let you
It
say.
could be poorly diagnosed as ADHD as well. It's very common, especially a lot of information out there is available, and there's a lot of overlap with symptoms as well. Any child that's difficult to control, it makes it harder for parents. Everybody's working, so everyone's trying to look for a solution. And even
Absolutely.
with a poorly diagnosed condition, if it's a solution, it's a solution. So it could be misjudged. The
Absolutely.
hyperactivity could
Yeah,
be
that's true. I
misjudged.
have a significantly high number of kids who have poor performance in school. They might
Mm-hmm.
be very combative, they might be very aggressive, they have poor memory, poor concentration, completely opposite from what you would expect from kid who doesn't get enough sleep or the quality of sleep is not good. And my experience of studies that many kids, let's say, if I focus on my area, problems with the tonsils and adenoids, kids who undergo these procedures, I'm always trying to be realistic in the expectations, telling parents that the breathing and sleeping will improve. But then they come, and as a feedback, they're saying the school performance increased. They are more calm.
100%.
They are,
Yes.
More receptive to
more,
what the
more.
parents wants
It's yeah,
them to do. Yeah.
It's huge. I mean, to
yeah.
think about it, Anyways, what would you think, Dr. Simran, an airway focused dentist like myself and a pediatric dentist like yourself should look out for?
So an airway-focused dental exam, it extends beyond the teeth. We pay attention to how a child breathes, how their jaws are developing, and how the oral structures are functioning. So some of the things that we may look at are, yes, we can look at the tonsils, for example, as a screening kind of tool. We can also look at the jaw positioning. So as Dr. Gertrude mentioned before, if they have, a protruded mandible, so that's a smaller lower jaw, it looks a little bit further pushed back. Also, if a child is able to achieve a lip seal, so can they close their lips together? And looking at the chin, so that's the mentalis muscle, is there any strain there? Is there any nasal sounds in their voice? And also as how the teeth are positioned together. So are the lower teeth, are they developing this kind of way round, which is something we call a crossbite, or is there crowding within the jaw? So these are things we look at. And finally, we also look at the soft tissues, so looking for any tethered oral tissues. So that may be some, as an example, a tongue tie. So is there any restriction in the soft tissues in regards to mobility or elevation, which in turn could affect their speech and their functions, such as eating. So it's a really comprehensive, holistic look
I see.
that we
Yes.
really take.
And is there a structured way to grade this clinically?
Yes, so as I mentioned, when we look at the tonsils, and I'm kind of verging into ENT territory as well, but we can see the tonsils, and we can grade the tonsils using the Brodsky scale. So that's the size of the tonsils in relation to the airway. And then we can also screen using the Mallampati scoring, which is essentially taking a look inside the mouth and just seeing the size of the airway, or so these two things are screening tools. So they don't necessarily diagnose a child with obstructive sleep apnea, but they are really useful screening tools that can help us make a diagnosis or help us go forward with the treatment.
Thank you for that.
Or possibly suggesting, like, a more objective test like the polysomnography is needed if these features are being picked up on. And I think one other key factor is your hyoid bone or the bone in the neck. So it could also have a more backward or caudal position, which is also compressing on the airway. So everything, because as Dr. Sasha said, it's a collapsible tube. So the whole idea is to look at how much of the collapse is happening from a physical obstruction. So as she mentioned, the Brodsky and the Mallampati, that's the ratio of how much is your airway blocked by these physical obstructions. So that could be a very important objective examination to then direct the child towards a PSG or a polysomnography.
Okay. So you just named the red flags basically that you would see in ortho
Yes.
for us. And how about on the ENT side?
On the ENT side, we inspect all elements of the upper airway, starting from the nose, postnasal space, throat area under the throat called hypopharynx. So we are using combination of different cameras that we call endoscopes. For kids, it's a little bit more appropriate to do one simple X-ray, which is minimal irradiation, not to stress them too much with too many of devices. Generally, what we are looking into in the nose would be possibility of deviated nasal septum and hypertrophy of the nasal turbinates, some potential sinus issues. They are much more common in adults. So again, in kids, most common problem for obstruction would be hypertrophy of the tonsils and adenoids. But okay, in the throat, we just don't assess the size of the tonsils, but we are looking at the shape of the palate, the shape of uvula, again, potentially tongue tie, mobility of the tongue, hypertrophy of the tongue.
And what would you say is the gold standard?
Gold standard for the diagnostics is the gold standard for diagnostics is still polysomnography. At the end, so there are two types of polysomnography. It's one in the hospital, and this one is measuring much more body functions and physiological functions, but not really necessary for obstructive sleep apnea. Now we have convenience of the tests which can be performed at your own home, and they are much more convenient for both adults and kids, and they are measuring body functions as levels of the oxygen, respiratory rate, snoring, and this is basically the gold standard for diagnosis of obstructive sleep apnea, which gives us one parameter that we called apnea-hypopnea index. Then this is of number of episodes when the patient fully or partially stops breathing in 1 single hour. So while for adults, this apnea-hypopnea index is something that we tolerate, and we usually say that up to 5 of these episodes per hour is something that we can consider as physiological. For children, even 1 of these per hour is considered pathological. And when we mention hypopnea is a moment when kid or adult stops breathing for longer than 10 seconds. So if there is snoring, if there is a little bit of gasping for 2 to 3 seconds, this is not apnea. But if it's lasting longer than 10 seconds, it's apnea. And if it happens even once in kids, this is considered something which can affect their body functions, the oxygen levels, blood pressure,
Wow,
pulmonary pressure.
crazy.
Yeah.
And does sleeping position have an effect on pediatric OSA?
Usually, they say that, especially for obese children or overweight children, if you're sleeping in a supine position, which is flat on the back, then that is known to be more predisposing
In adults as well.
in adults as well, yes. So sometimes sleeping on the side is recommended just to eliminate that compression of the airway when you sleep on your back. So the supine position is definitely more predisposing to having more episodes of apnea and hypopnea, as Dr. Sasha explained.
And Dr. Simran, would you like to add to that?
So sleeping position, it can affect symptoms, but it's not usually the main cause. So even still, if a child is struggling to sleep throughout the night or snoring, we still need to evaluate the airway rather than just relying on changing a sleeping position at nighttime.
Okay, thank you for that. And Dr. Sasha, back to you again. Let's go through treatment options carefully. What can be done if a child is diagnosed with sleep apnea?
So once when we have child diagnosed with sleep apnea, we can try conservative options, or we can discuss with the parents even some surgical options if there is some evident blockage of the airway with the physical masses of tonsils and adenoids. In terms of the conservative medicine, we can always try some anti-inflammatory medications which are going to reduce inflammation in the upper airway. I'm primarily thinking about the corticosteroid nasal sprays, which even if they sound, when you say corticosteroids, they're absolutely safe to be used even for a couple of months without any potential side effects because they are just applied locally. Weight reduction definitely for kids who are obese, because this is one of the most important outside factors apart from the internal anatomy. Orthodontic appliances for kids who are candidate for this, and potentially CPAP, although the problem is compliance with the CPAP, not just for kids, but also a huge problem in adults.
In adults, right.
It's almost something that is, it's extremely hard to apply this in kids. Surgical options, they mainly include removal or reduction of tonsils and adenoids. These are nowadays done with the power devices, lasers, radio frequency devices, harmonic scalpel. So these are completely bloodless procedures, which extremely fast recovery and extremely
Perfect.
high satisfaction rate.
And Dr. Gayatri?
So, orthodontically, as I was talking about what the child presents with, that is correlated strongly with the treatments that we offer. So, if a child presents with a narrow upper jaw or a like retrognathic upper jaw, which is a jaw that's not growing adequately in the front back direction, then we do a simple expansion device. It's called a Hyrax expander, to just expand the jaw sideways. Once the jaw is expanded sideways, it allows the tongue to go and sit, as I say, hug the roof of the mouth, and that sort of reduces. And this is, I think, one of the most beneficial treatments that we can offer, because across studies, across evidence, this is definitely respected. This is definitely very welcome. It is that expansion of the upper jaw definitely reduces the nasal airway resistance, and it promotes the child to breathe from the mouth or from the nose as well. So this is definitely extremely helpful. Along with that, an expansion device can also be supplemented with something called as a protraction face mask, which is a very safe device, gold standard treatment. Again, it goes on the child's face and you just wear rubber bands to have a forward effect on the upper jaw. And this also allows the lower jaw to go down and back, which just allows more room in the mouth, allows a positive direction of growth for the upper jaw, which can also expand the airway at the nasopharyngeal level. Another treatment option is a mandibular advancement device. And again, a lot of children with retinognathia or reduced growth of the lower jaw, even if they don't present with symptoms that we could correlate to airway symptoms, these are treatments we definitely do provide at the right age. So pre-pubertal for the lower jaw growth is the best time to allow like maximum benefit from the treatment itself, because it correlates with the time where the lower jaw is naturally growing. So these have been reported by patients itself as added advantages. Back when they didn't report the symptom when we started with the treatment, they came only for a increased overbite, patients commonly like to call it, or his teeth are forwardly placed, or the teeth look like they're flaring out of the mouth. And then this was something that just was reported randomly. Like once we did the forces appliance or we did another form of MAD, the parent came and said, okay, he doesn't snore at night anymore, or he's completely stopped waking up at night or snoring at night. And then I've thought back, and of course this would be something we could do for the lower jaw as well. So I think again, it's very, very correlated to the symptomology or the clinical sign that a child presents with. But I think again, an expansion device, a device that allows the mandible or the lower jaw to be positioned forward, or a face mask sort of device which allows more growth on the upper jaw. These are early treatments that we can offer, which can even reverse the craniofacial symptoms of mouth breathing, which is a long face syndrome.
Wow, this is truly amazing. And Dr. Sasha, when is adenotonsillectomy considered the main treatment?
If you have kids with any other significant comorbidities, meaning that the child is not obese, no any significant craniofacial abnormalities that you can correct with orthodontic procedures, and massive tonsils and adenoids. So I will repeat again, I sometimes have these children who may have 90% of the back of the nose blocked with massive adenoids. And I tell parents, imagine that you have room which is 90% filled with boxes, and you remove all these boxes and how much more space you are going to get. So again, these are extremely safe, extremely quick, extremely gratifying procedures. So if you choose the right kid for the surgery, they're going to be happy ultimately.
Fingers crossed. And can medications help, such as intranasal?
They do. They do. I
Steroids?
mean, they cannot
mean, there's
decrease.
steroids at the end of the day.
Steroids at the end. Most of the medications that we are using are steroids. Sometimes we can try with antihistamines. I never use oral corticosteroids in children for that purpose. But again, nasal steroids, they're absorbed locally. They are FDA approved even for pregnant and breastfeeding women. Their systemic absorption is minimal, so they can safely be utilized in kids even a couple of months. They decrease inflammation. So if kid is having concomitant allergy, adenoids may also be inflamed, not just big in size, that this inflammation production of mucus, they are going to be decreased. Unfortunately, I had few times requests by parents to repeat X-ray after the course of nasal steroids. Adenoid tissue does not shrink. This is solid tissue which may shrink by itself over a longer period of time. They generally, for most of kids, they start shrinking before teenage, but short course with the steroid nasal sprays, again, they can reduce inflammation and bring some relief, but not really change the size of the tissues itself.
Amazing. And what is your role as an orthodontist, Dr. Gayatri?
So I was just explaining, I think it's also an overlap with the ENT. As I mentioned the appliances before, sometimes these appliances may also need to be supplemented with an adenoid tonsillectomy because, I may be able to expand the upper airway, which may reduce the resistance to the nasal airflow, but then it wouldn't have an impact on the size of the adenoids, like the sprays wouldn't work for them. So there may be an important step here to be able to have regular follow-ups on the expansion, understand that when the child does not have any other viral infection where these symptoms become more heightened, to then constantly, again with the Malampati scoring, have an idea of, are the adenoids shrinking, are they maintaining their size, and if we don't see a lot of symptomatic relief, it would be very important here to have a record of the size of the adenoids and then be able to refer to the ENT for a removal. So this would be something that could be correlated with orthodontic treatments. Again, which part of the airway is the issue,
Right.
and where that problem is the most severe, and so then that area needs to be explored. So if it is the oropharynx or anything below that, then Dr. Sasa has to be involved.
It really does take teamwork, as we're seeing this more and more. And either of you that want to answer this, where does CPAP come in?
So CPAP, it stands for continuous positive airway pressure. And it's usually when other treatments maybe haven't resolved symptoms. So it's not the first line jump in kind of treatment. And it's essentially where air is gently delivered through a mask to the child whilst they're sleeping at nighttime. And we can consider CPAP for children perhaps with residual OSA, or for children with craniofacial or abnormalities, neuromuscular disorders, or children who slightly are overweight and maybe weight management, they haven't been able to reduce their weight. So it's typically not the first line, but it can be, recommended if for more complex cases or persistent cases.
Amazing. And I think I'll throw this back to you, Dr. Sasha. Does every child with mild obstructive sleep apnea need treatment?
Not necessarily. I mean, all depends on symptoms and perception of the parents. I always talk to parents trying to get as much information as possible about activity of the child, about performance in school, about some subjective impression of the parents. Communicative bigger kids aged 5, 6, they may complain by themselves and they may say there is a problem or there is no problem. So again, as we discussed, it's a complex problem and not just something that is black and white. And as I said, tonsils and adenoids, this ENT area of obstructive sleep apnea in children, they change with the time, not overnight, not over a couple of weeks, but they may shrink over the period of couple of years. So you may have kids who are at the age of 3, 4 really having witnessed
Difficulties, yeah.
typical apneas, and they get
Outgrow
better
it.
as they grow out. It's very unpredictable. Tonsils and adenoids, they can remain the same, but the kid is growing and the airway is expanding. And of course, there are other factors like obesity, other things which can be corrected. So when I'm seeing these kids, I'm trying to help, but again, I don't want to push anything, and I'm trying to just get along with the problems and try to fix the problems that are observed by parents and maybe connect them with potential treatment that I can recommend or offer.
Makes sense. And I love this part of the podcast because I'm going to say one more time to each and every one of you, and we'll start with Dr. Simran. What is one last thing that you didn't mention today that you want to reach out and inform parents about?
So if your child snores regularly or wakes up frequently throughout the night, or is even bedwetting, these are not harmless symptoms or symptoms to think my child will just grow out of it. So my take-home message is please do come and get it checked out, because it can really have a knock-on effect on the quality of life for your child, including their school performance, their mood, their behavior. So it really does have a knock-on effect on all aspects of their life.
Thank you. And Dr. Kayasri?
I think I would build on that by saying that, some of the jaw presentations, if they're treated early and if airway can be looked into early, then there can be a complete reversal of the picture that a child presents with, with early examination, early treatments. And secondly, I think as Dr. Simran said, once it improves the quality of life or their behavior, I think their peer relationships with the parents also improve, because then parents are just spending more quality time with their children rather than, struggling to get them to do the daily routines and activities. So, we can help with that.
And Dr. Sasha?
Yes, so pediatric obstructive sleep apnea is not just a noise, it's a health problem. So as Dr. Simran said, it's not just affecting the proper quality of breathing and sleeping, but also can affect behavioral characteristics of the kid, performance in school, attention. From ENT perspective, the most common reason for pediatric sleep apnea are enlarged tonsils and adenoids, but these are not the only ones, and that's we are working as a team over here.
So do not wait for extreme episodes of choking to happen to take this snoring seriously. Pediatric OSA, again, can affect growth, learning, behavior, heart health, metabolism, and quality of life. When this is recognized early, treatment can be very meaningful, and I wholeheartedly believe in teamwork. as you guys have all known, in the past 22 years here. And LH has been brought from the grounds of a teamwork. And as you see, our lovely airway team here today. And when there's that team all under one roof, it just makes things so much easier. So, as we have the airway, the sleep, the dental, and the ENT, all aspects evaluated here at Leila Hariri Dental. Please don't take snoring lightly and mouth breathing lightly. And until next time, stay safe, everyone. See you soon.